Hello and welcome to a special interview for The Wire supported by Glenlivet Books. Although in a surprise announcement late on Christmas night, the Prime Minister has authorized boosters for the elderly and the vulnerable, there is a critical question that hasn't been answered. And with every passing day, the need to answer it goes greater and greater. Does India have credible data to establish the efficacy of the vaccines that are being given? Or does the country suffer from what's called data denial, data paucity, and data opacity? That's the key issue I shall explore today with Professor of Biostatistics, Epidemiology, and Global Public Health at the University of Michigan in America, Bhramar Mukherjee. Professor Mukherjee, in a recent set of tweets, you said that India's COVID-19 data suffers from data denial, data opacity, and data paucity. And you say this will only make it harder to navigate solutions. Can you start by explaining what exactly does data denial, data opacity, and data paucity amount to?
Thank you, Karan, for sitting down on a holiday morning to talk about data, which is really close to my heart, and a happy holidays to all your viewers. So I do think that a credible and a neutral, politically neutral, autonomous data system is really essential for a well-functioning democracy. And I'll give you why I chose those three words, data denial, and some examples so that people resonate what we are and try to appreciate what my concerns are. So for example, data denial. And throughout this pandemic, we have seen several examples of that. By that, I mean that we have available data. It is staring at us, but we are unwilling to accept what it is telling us and take actions. For example, community transmission in India. For the longest time, we saw all the data, which really told us that the virus is everywhere and every case cannot be identified to its source, but we still fought that concept. So that I will call data denial. Similarly, during the second wave, when it was very clear where this is going, even from February or early March, the projections were dismissed. So this is where I would say data is there, but we are trying to deny it for some prejudices or preferences or motivations. I do not know, but this is data denial. And then the second thing is data opacity. So let me give an example, India's death data. All over the world, epidemiologists are really struggling to quantify how many people have died in India in 2020 and 2021. So we recently did a meta-analysis of all the studies published in India, and the estimates are all over the place. So this is data opacity, and there have been some correction to the death estimates that really distorts some of the estimates as well. So because, in August or in June, if you have certain days with a very large number of deaths, that's very hard for the models to capture. Then the third thing, I think, which is really prevalent and really bothering and interrupting our work is the limited data that are available in the public domain. And it's as simple as if I want to know, and I have been modeling this pandemic for the last 2 years, so I think it's very legitimate that I would like to know what is the breakdown of cases, hospitalizations, and deaths across age and sex, and now according to vaccination status. I cannot find it. So I think that in order for me to run a model which needs to know reinfection rate and breakthrough infection rates, there is tremendous data paucity.
I heard the distinction between the two. Let's leave data denial aside because that is not something we can tackle. Just mark it that there is a lot of data which we simply deny the existence of. We won't respond to it, such as to do with projections, such as to do with, in fact, the belief that we have community transmission and didn't accept it. There's also data opacity, which is illustrated best of all by the utter confusion about the number of people who've died. As you say, the estimates vary all over the place. And Ramanand Lakshmi Narayanan has just done a projection which suggests that, in fact, the total deaths in the country, based upon a extrapolation from Chennai, could be 6 million. But that's opacity. I want to focus instead on the third category, data paucity, because I think This is critical to the issue of boosters. I know we have data of the number of people who've been given vaccinations, but do we have data on number of people who got infected, reinfected, breakthrough infections, hospitalization, serious illness, need for oxygen, need for ICU, need for ventilators? Do we have any of these separate categories of data?
So if it exists, it belongs to people that I do not know. So I do think that there are some very good databases in India. For example, CoWIN in itself, just recording vaccination, is an excellent database. So we run an app. And the reason I know this, because we run an app which actually amalgamates and integrates data from different sources from wherever we have. So we need the testing data. And the testing data is very problematic because you can get national level testing data numbers, but then in order to get state level, it's basically web scraping, and it's available in different websites and official websites as well as media websites. So that's the testing data. And then the Ministry of Health and Family Welfare do release the case death count data and active number of cases. But I have never seen hospitalization data released, the daily hospitalization series. And I tell you, like, this is really becoming important now, because particularly the Omicron wave, we're going to come to that in a minute. So what is not happening is the vaccination data, the testing data, and the clinical data cross-talking with each other, plus the sequencing data, so that we can make meaningful numbers that these are truly reinfections, or this infection happened between 2 vaccine doses. So yes. In summary, the answer to your question is no.
But you're saying something fundamentally very important. You're saying, first of all, you don't know if the data in the breakdown way that I illustrated exists or not. If it exists, it's privileged. It's not made available to people like you. It's not made available to scientists, epidemiologists, virologists. So we just don't know whether it exists or not. We assume and we hope the government has it, but we do not know for sure. That's the first worrying thing. The second is, even more important, you don't know whether this data has correlated and speaks to each other. It might therefore simply exist in individual separate silos.
Exactly.
I think
that's the main problem.
But you know what that means, Professor Mukherjee, and I'm putting it to you, so correct me if I'm wrong, that if the data is not correlated, then we do not know how many people who got one infection went on to get a second one. We don't know how many people after 2 jabs got a breakthrough infection. We don't know whether that led to serious disease, whether it led to hospitalization, whether that hospitalization required oxygen or ventilators or ICU. None of those details are known.
So that is exactly precisely the problem. So if I am considering, suppose I'm not vaccinated and I'm considering whether I need to take the vaccine or not, the first thing I want to know is that there has been almost a year of vaccine rollout. How many infections and hospitalizations have happened in the vaccinated? What percentage? And also in the partially vaccinated or in the unvaccinated. These numbers are very powerful. Them staring at me will motivate me to go for the second jab, or if I'm not vaccinated, go for the initial shot. I also want to say that if somebody told me, yes, this is how we have tracked the data, this is the number of infections, this is the number of hospitalizations in the vaccinated over time, and there is no evidence of waning, then I'll say, well, I rest my case against booster.
But
or
Professor
if somebody
Mukherjee,
says,
you're making a
sure.
much more important point. It's not just that the presence or absence of data will not convince individuals, but you're making a more important case. If we don't know how many cases of breakthrough infection we had after double vaccination, what sort of illness they led to, whether they required hospitalization, oxygen, ventilators, or ICU, then we do not have data on the efficacy of our vaccines. That's what this amounts to.
So definitely effectiveness of vaccines, and also people, consumers are interested in knowing comparative effectiveness, right? So many people are getting different types of vaccine. And so we have a right to know what are the properties of these vaccines on the population.
Absolutely. But then this is getting worse and worse as we carry on this discussion. We do not have data that will establish the efficacy of our vaccines. I should put in a codicil here that if the data exists with the government, it's not been made public, it's being hidden. And why the government would hide that data, no one understands. Why it wouldn't make it public to support the policies it's taking, no one understands. So if the government doesn't talk about it, one has to be very clear in saying, this means the government doesn't have it either, because silence doesn't suit the government. So what we are now coming down to is saying we do not have credible data in India to establish the efficacy of the vaccines, neither Covishield nor Covaxin. So then on what basis does the government announce that we need to wait 9 months for another jab? On what basis have they decided that immunity will not wane after 6 or 7 months, but 9? And I should point out to you that some newspapers are saying the government's position is wait for 12 months, not 9. So what's the basis for that? Just guesswork.
So I would guess, this lot of scientists are involved with the government in determining policies. So perhaps we are borrowing from the literature in other countries, and there is a scientific report. But as a world citizen, I would like to know, India's vaccination data has a lot to offer to the world as well.
But can I interrupt you again? If we're borrowing from the data and studies done abroad, then a 9-month gap, leave aside a 12-month gap, makes no sense. All the data abroad says it wanes after 6.
That's exactly what I'm saying, that there may be studies that they're looking at that I am not aware of. So, if I log into my health portal in Michigan, I see I'm due for the 4th booster dose. And so they are recommending possibly every 6 months. And how can things be so different across countries? So that's why I need to know, actually, that what is the data these recommendations are based on.
But there's another conclusion that is emerging from our discussion. First is the conclusion that we simply do not have credible data that judges and assesses the efficacy of the vaccines. Therefore, we don't know on what basis the government is saying immunity wanes after 9 months. Some papers, as I say, are saying it's going to wane after 12. All the data abroad suggests immunity wanes after 5 or 6. But there's another problem. We're flying blind. If we don't have data, we're flying blind. We're making up policy on the basis of other factors, such as political convenience, right? Or such as quantity of vaccines that are available, not on the data. That is even more worrying. Flying blind is not necessarily the best way of flying.
That is absolutely right. So I think that there is also, we are talking about vaccines and the vaccine database primarily, but I think the fact that we are not tracking hospital admissions is going to become very, very critical in the coming months. For example, if Omicron, with very highly transmissible, truly leads to a lot of just mild infections, and we have nothing to worry about, we need to know that people are not getting into hospital from vaccinated arm or unvaccinated. What is the difference in terms of those admission rates in order to convince people? But also, I think that this is the important key metric. We might really overkill and say, oh, cases are going up. We need these intervention measures. We need lockdowns or night curfews and so on. Whether it may not be that critical. If we don't know hospital admissions data, we can never do accurate projections. So it is going to be overkill.
Absolutely. It's not just the efficacy of our vaccines that we cannot establish in the absence of data. We also don't know what other preventive measures to implement. We don't have the data to justify doing so, which is why, bizarrely enough, when cases are just reaching 290 in Delhi, we're considering declaring lockdowns and odd and even systems, and there's no basis for this. Now, let me put something to you. In comparison to the paucity of data in India, How is data in South Africa? How good is it? I know the world applauded South Africa for the speed with which they identified and notified Omicron. I know the world has applauded South Africa for the extensive research they've done thereafter on efficacy of vaccines, severity of disease, and the age profile of the infected. So let me ask you bluntly, how does the South African handling of data compare with India?
So as I mentioned, that I think that the virus is not just confined to the national boundaries, and so data should not be either. Many scientists working together on the South African data really helped us with figuring out what Omicron is doing. And scientists, really hats off to them, even after these 2 years, just working round the clock to figure out the properties and running simulations.
Hang on a second. Are you saying South African data is infinitely better than India? Please answer that question.
So if for example, I have never seen age stratified sequencing related data from India, so I have no base of comparison. So we are comparing no data. So almost anything is better than India by that argument, because we have not seen this kind of data.
Well, just a moment. Within weeks, and not even months, within weeks of Omicron being established in South Africa, we knew from South African institutions the efficacy of Pfizer. We knew about the rate of greater reinfection caused by Omicron. We knew about the rate of greater breakthrough infection. We know about the age profile of people who have got Omicron. We know about whether they need oxygen or whether they are doing well on room air. All of that we know. We know none of that in India, even for Delta, leave aside Omicron. So I come back to my question. It's so important. Is the South African handling of data better than India?
That is exactly what I was going to mention, actually, that the Delta variant, which originated in India, but most of the key papers actually came from the UK. And we have subnational data from some pockets of India, but nationally representative sequencing data largely absent. Look at Israel, right? How good they have done with respect to monitoring their sequence of vaccination and case counts and infections. So when Israel actually noticed this waning effect of the vaccine breakthroughs, they alerted the whole world. This is the responsibility of any country to connect their vaccination with infection, with sequencing, to tell us which vaccine is effective against which variant.
Let me ask you a simple question, and I'll ask you for a blunt and honest answer. Please don't prevaricate because you're shy of being critical of India. I think we owe it to our people that if the answer requires criticism, we be critical. How does India's data compare with the world?
I do think that India's data will be, in general, I think that India's disintegrated data system, maybe their data exists in pockets, but it's not in usable format to get to an analytic model to really extract information. So I would say that it's a very impoverished data infrastructure, and it's really a pity because we could learn so much about subgroup specific effects of vaccines. The world is deprived of the knowledge.
How much problem are we creating for the world? Not just ourselves, but the world, because our data is so poor and it's not made public. After all, remember, we've given 1.4 billion jabs, the second largest number after China. If that data were good, it would be of huge value to the world. So how much problem are we creating for virologists, epidemiologists, and global public health experts worldwide?
No, this is just, I think it's incredibly unfortunate and disappointing that there is such an incredible learning opportunity going on here. Even in terms of the natural experiments that we saw over the last 2 years.
You're not answering my question. Please answer my question. It's so important. You come from a university which is recognized for the work it does on data projection. So please answer my question. How much problem is data's paucity in India creating for virologists and epidemiologists?
Again, as I said, that it is impossible to keep a basic app, which is an epidemiologic tracker, running. If you look at why some of the modeling effort was possible, it was actually by the gallant effort of a group of volunteers covid19india.org, and now covid19bharat.org. Otherwise, the little bit that we did in real time would not be possible because we'll spend so much time in cleaning and integrating data. So this is embarrassing. We should have better data which are cross-talking so that we can do real-time projections. I always say that we have tons and tons of models which need input parameters, and we need data in order to come up with credible projections so that, again, these public health interventions that we are rolling out, which have crushing consequences, may not be needed in some places, but we don't have the ability to do this, to say so.
You said something very important. India's data is embarrassing. Thank you. That is quite clear. You also said something else. The excellent data that was available on covid19.org, which has now become covid19bharat.org, is actually put together by volunteers. They have actually made the effort of putting it together from different individual sources. It's not data made available by the government itself. And I end by repeating the very important thing you said. If data that correlates infection, vaccination, reinfection, breakthrough infection, hospitalization, ICU, ventilator, oxygen exists, it's not being made public. And since it would be to the benefit of the government to make it public, one can only assume the government also doesn't have it, but that's an assumption. Also, we don't know whether that correlation is taking place so that it speaks to each other, because if it did, with certainty, we'd be able to say boosters are needed after 6 months or 7 months or 9. We wouldn't be in a position where today the papers are utterly confused about the gap. Some say 9 months, some say 12. Papers are equally confused about what vaccine should be given as a booster. Some say those who had Covishield will get a third jab of Covishield. Others say, no, it will be mix and match. So clearly, there is not just embarrassment, but there is also absence of substance, absence of data to justify policies. They're all being made on the hoof. And as you agreed, we therefore seem to be flying blind. It's a bit like that saying, on a wing and a prayer.
I also want to mention one thing, that in the absence of national level data, the subnational data that we are seeing, for example, the death data, for example, it's also really unfortunate because we need an overall representation for India, right? People who are not represented, data from rural India, data from mid-sized small towns, not only urban metrocentric data. So data and unrepresentative data can also take the voices of the invisible away. And this really bothers me, that whatever data we have is not representative of the entire India.
I hope, Professor Mukherjee, that those in authority are listening to you, and I hope they heed what you have said, that this is embarrassing. It is holding up the work of virologists and epidemiologists. It also means that we don't have substance and basis for the policies we're implementing. And as we've said many times, it therefore suggests we're flying blind. Thank you very much for shedding light on a critical issue of fundamental importance. Take care, stay safe, and have a great holiday.
Thank you so much. I just want to mention that public trust in data is extremely important, and it's not just India. India has a responsibility to the world to share this data and democratize the work that, the data that we have gathered and generated by the largest vaccination program.
I agree with you. India has a responsibility to the world to share its data, and at the moment, it's not only not sharing it, but as you and I have just established, it's quite possible that it doesn't have it to share in the first place, and that would be even worse. Oh dear.
So that would be our 2022 wish, New Year's wish for India and for all of us. Thanks so much, Karan.
Thank you very much indeed. Take care.